Now about the epiglottis. Epiglottis abscess usually occur on the lingual side. It's the normal epiglottis. It is the lingual size of epiglottis. It's in the normal larynx, but in that picture we can see it is the epiglottis, and may be diagnosed by direct visualization. Acute epiglottis is a rapidly progressive infection causing inflammation of the epiglottis and tissues around the epiglottis, and that may lead to abrupt blockage of the upper airways and death. A number of factors can cause the epiglottis to swell: burns from hot liquids during injury to your throat, and various infections. Epiglottic abscess is a common complication of supraglottitis, and it occurs more commonly in adults than children. The most common cause of epiglottitis in children in the past was the infection with Haemophilus influenza B type, and can occur at any age. Management involves immediate operative airway management followed by drainage. In children, the signs and symptoms of epiglottitis may develop within a matter of hours. The fevers, the severe sore throat, abnormal high-pitched sound and when breathing in, the difficult and painful swallowing, drooling, anxious, restless behavior, feeling better when sitting up or leaning forward occurs. Now in that slide you can see it is the laryngoscopic view of the different stages of the acute epiglottitis, and it is the X-ray sagittal view of the larynx, and we call this the thumb sign here. What's the phlegmonous laryngitis? It's a suppurative inflammation of the mucous layers, possibly of the mucous tendons and the laryngeal perichondrium, and its etiological factor is infection. The disease occurs mostly in males aging from 20 to 35. The infection can be circumscribed and diffuse. The patient complains of the severe pain on swallowing, especially if the phlegmona is located on the tongue surface of the epiglottitis and the arytenoid cartilage. If the glottis tissues are affected, the first symptom is a hoarse, barking cough, which we call this as and respiratory distress to asphyxia. The body temperature is high, and examination reveals inflammation of the regional lymph nodes. During the laryngoscopy, we can reveal the hyperemic and infiltrated laryngeal mucosa with the situs of the necrosis. The formation of an abscess is characterized by circumscribed swelling. Pus can be seen through the thinning mucosa. Mobility of some laryngeal structures is strongly restricted. The patient must be taken to hospital. The tracheotomy is indicated for increasing stenosis. The general antibacterial and anti-inflammatory therapy is started at the early period of the disease. If an abscess is present, it should be opened surgically. If the phlegmona spreads onto the soft tissues of the neck, external incisions are made to ensure adequate drainage of suppurative cavities. Now about the croup. What's the croup? It's also divided, may be classified as a false croup, which we call this the laryngotracheobronchitis, and true croup. The true croups, it's the equivalent with the diphtheria. Even here we can see it is the healthy throat, it is the laryngeal, it's the sore throat with the false croup, and it is the view of the diphtheria. And we call this the true croup. The difference of the epiglottitis and croup, you see the etiological factor in epiglottitis, it's the Haemophilus influenza. During the croup, I mean just the false croup, it's the parainfluenza virus, because during the two croups, the etiological factor is the Loeffler, Bacillus Loeffler, the diphtheria. Croup, it occurs between the age group, it's between the 6 months and the 3 years, and croup happens gradually. Epiglottis happens there rapidly. During the epiglottitis, it's located in supraglottic area. The false croup, it's the subglottic area. It's damaged, and others symptoms also differs from each others. The laryngotracheobronchitis is a contagious viral infection causing inflammation and swelling of the larynx and surrounding tissues. It presents with difficulty in breathing, especially breathing in a typical barking cough. It usually affects children between the ages of the 6 months and the 3 years. It is the view of the laryngoscopic view of the croup. During the croup, it is the characteristic view, X-ray view, and we call this the stipple sign here. The narrowing of the stipple sign is related with the narrowing of the subglottis area. This is an inflammation of the upper and lower airways due to the viral infection, specifically an acute and severe infection of these parts marked by swelling of the tissues and excessive secretion of mucus leading to more or less complete obstruction of the respiratory passages. The pathophysiology is related with the prodrome of the several days of fever, and symptoms of mild upper respiratory infection are common. As the infection extends to the proximal trachea, diffuse inflammation is exudate and edema of the subglottic area causes narrowing of the airway. The cricoid ring of the trachea is the narrowest portion of the airway in a child. A small amount of edema in this region can cause significant airway obstruction. The virus is causing inflammation of the trachea, the larynx, the bronchial tubes, the small bronchial tubes, and the lung tissue. The most prominent feature is the swelling and obstruction due to fibrinous inflammatory material in the subglottic area, the area underneath the vocal cords. This leads to an stridor and difficulties breathing. The symptoms of croup, it is typically the child suddenly awakes in the middle of the night with a barking cough, a stridor, and fast breathing creates a respiratory distress. If the symptoms were not bad enough in the first night to go to the emergency room of the hospital, the symptoms get better during the day, only to worsen the following night. Typically, it peaks on day 2 or 3 of the disease. And the treatment, it's very important, dehumidification. They provide oxygen to all hypoxic patients. The L-epinephrine is an effective erasmic epinephrine. Corticosteroid therapy, anti-inflammatory therapy, antibiotic therapy, desintoxication and dehydration and sedation therapy is important. Now about the chronic laryngitis, you see it is the typical view of the chronic laryngitis. You see the vocal cord dull red, the swollen and rounded. It's another view of another laryngoscopic view for the chronic laryngitis. The etiological factors include we say the every factor can affect the vocal folds, the physical, chemical, even infection. The excessive vocal use, just a voice load, just a vocal issue, habitual shouting, long-term inhalation of irritated gas, chronic airway infection, and acute laryngitis procrastinating. All this is the vulnerable, all this the leading to chronic laryngitis. The symptoms include the hoarseness, vocal fatigue easily, discomfort, and a tendency to clear the throat constantly, cough with the wide sputum. The signs may be just the 3 kinds of laryngeal changes that maybe there are so many interesting classification, but one of them is we include the chronic simple laryngitis, chronic hypertrophic laryngitis, and atrophic laryngitis. The clinical classification, it's another classification. It's classified to non-specific and the specific laryngitis. The specific one includes the tuberculosis, syphilitic, leprous, scleroderma, vaginous, and mycosis of larynx. The chronic non-specific include the chronic simple, hyperkeratosis of larynx, or chronic keratosis, we call this leukoplakia, pachydermia laryngitis, contact granuloma, and atrophic laryngitis. It is the chronic inflammatory disease of the larynx is in the majority of cases secondary to acute inflammations. It may follow incompletely resolved acute simple laryngitis, presence of chronic infection in paranasal sinuses, teeth and tonsils, and chronic chest infections. Occupational factors, example exposure to dust, fumes, and other chemical components, smoking, alcohol, vocal abuse are important contributory causes. The three forms of chronic inflammatory disease of the larynx and the trachea are now distinguished. It may be catarrhal, hyperplastic, and atrophic. Chronic catarrhal laryngitis, the most cases secondary to acute laryngitis. The main etiological role of this pathology in singers, actors, lecturers, each others. It is the occupational overload on the vocal apparatus. The laryngoscopy revealed congestive hyperemia of the laryngeal mucosa, which is more pronounced in the region of vocal folds. Blood vessels are often dilated. The treatment is aimed at eliminating an etiological factor. The patient must rest his voice. Local therapy includes instillation of an antibiotic solution containing hydrocortisone suspension. And now you will see just in this slide the chronic hypertrophic laryngitis view. In the vocal cord, it's appears swollen, it's the red rounded, and edge is irregular. Chronic hyperplastic laryngitis is characterized by hyperplasia of the laryngeal mucosa. Local and diffuse forms of the disease are distinguished by the extent of involvement. The main complaint of the patients is hoarseness and even aphonia, which are usually due to uneven thickening of the vocal folds and paresis of the vocal muscles. Direct and indirect laryngoscopy reveal hypertrophy of the mucosa, which is usually symmetrical on both sides of the larynx in the interarytenoid notch. This hyperplasia can, however, be malignant, and the diagnosis of chronic hyperplastic laryngitis should be established not only by observing the clinical signs of the disease, but also by the histologic and cytologic findings. The treatment is in the first instance directed at removing the causative factors. The talking must be prohibited. Exacerbations are treated like acute catarrhal laryngitis. If mucosal hyperplasia is significant, a 2-3% silver solution is applied every other day during the course of 2 weeks. The chronic hyperplastic laryngitis may appear as just singular nodules, leukoplakia, pachydermy, and the larynx edema. The pachydermy larynx is characterized by helping of the epithelium in the interarytenoid region and vocal process of arytenoidosis. Exact etiology is not known, but disease mainly affects males who indulge in excessive smoking and alcohol. When the chains are confined to the vocal process, disease is termed as contact pachydermy or contact ulcer. Hoarseness or huskiness of voice is the main presenting feature is due to faulty approximation of cords. Hawking stand desire to clear the throat. This is because mucus keeps sticking in the interarytenoid region. Examination shows helping up epithelium in arytenoid region, which may extend to vocal process and is sometimes arytenoids. On phonation, it stands out like a coxcomb. Biopsy is essential to exclude tuberculosis or carcinoma. It's the example for the laryngoscopic view for the leukoplakia. Another example for the leukoplakia. Its leukoplakia or keratosis are also a localized form of epithelial hyperplasia involving upper surface of one or both vocal cords. It appears as a white plaque or a wart grows on the cord without affecting its mobility. It is regarded as cancerous conditions because carcinoma in situ frequently supervenes. Hoarseness is the common presenting symptom. The treatment is stripping of vocal cords and subjecting the tissues to histology for any malignant change. Polypoid degeneration of vocal cords, the larynx edema. It is bilateral symmetrical swelling of the whole of membranous part of the vocal cords, most often seen in middle-aged men and women. This is due to edema of the subepithelial space, which causes the laryngeal space of the vocal cords. Hoarseness is the common symptom. Patient uses both cords for voice production, and this gives him low-pitched and rough voice. Vocal cords show pale, translucent fusiform swellings. In that slide, you can see the laryngeal edema. Polypoid, another name, it's the polypoid chorditis. It's characterized by edema vocal cord. It's related to the proliferation of lamina propria with chronic irritations. And treatment of laryngeal edema is rehabilitation with microlaryngeal stripping mucosa on both sides and sagittally, not up to anterior commissura. Voice rest and speech therapy is very important. But never make a diagnosis of chronic laryngitis until other lesions causing hoarseness have been carefully excluded. Differential diagnosis should be with laryngeal tuberculosis and syphilis, laryngeal carcinoma, vocal cord paralysis, and hysteria. The treatment of chronic laryngitis, it includes the elimination of upper and lower respiratory infections, avoid irritating factors, voice rest, speech therapy, steam inhalation, and supportive measures. How we can improve our vocal hygiene? And drinking a lot of fluids, drink 7 to 9 glasses of water per day. Also good are herbal tea and chicken soup. Maintaining good general health, avoiding smoking, eating balanced diet, avoid dry, artificial interior climates, don't eat late at night, use a humidifier to assist with hydration. Now about the atrophic laryngitis, it's usually connected etiologically and pathogenetically with atrophy of the nasal and prenasal mucosa, the pollution of air with dust or gases. Smoking and abuse of alcohol are among the provoking factors. Patients complain of dryness, tickling, and the feeling of a foreign bed in the throat and the progressing dysphonia. In the early period of the disease, laryngoscopy reveals bright hyperemia of the mucosa, which looks lustrous. Now, it is the example of the laryngitis sicca. If you remember, we see that between the two vocal cords and between the two and false vocal cords, there's the ventricle. In the ventricle, located the sulcus. When the sulcus it's atrophied, it leads to the sulcus provide the humidification of the vocal cords. But when this sulcus is decreased in function, it leads to laryngitis sicca. The patients, the treatment, they must not smoke or take irritating food. He should rest his voice. Preparation, staining sputum, and facilitating its expectorations should be given. The throat irrigation and inhalations solution should be performed. Now, in order to stimulate the action of the glandular apparatus of the mucosa, we need to use some drugs. Now about the stenosis of the larynx. The acute stenosis occurs suddenly or develops within a comparatively short period of time. The main pathophysiological factors that should be assessed immediately in acute stenosis of the larynx are the following: the degree of external respiratory insufficiency, the body reaction to oxygen deficit. The body resource cannot be realized during acute development of stenosis. The adaptation reactions of the body are respiratory, hemodynamic, blood, and tissue reactions. The respiratory reaction is manifested by dyspnoea, which increases ventilation of the lungs due to deeper breathing and higher respiratory rate. We divided the acute and chronic stenosis. The local inflammatory disease, laryngeal edema, the subcortical laryngitis, the chondroperichondritis, and laryngeal angina. It includes the local inflammatory disease. The tumor and allergy, it's related with non-inflammatory origin. The hemodynamic compensatory reactions are characterized by tachycardia and increased vascular tone, which increase the minute blood volume 4 or 5 times. In these conditions, increasing the stenosis induces severe pathologic reactions. Acute stenosis of the larynx can be caused by local inflammatory diseases, such as the laryngeal edema, acute infiltrative or abscessing laryngitis, chondroperichondritis of the larynx, or submucous laryngitis. Local inflammatory processes various injuries foreign bodies and each other. Acute infectious diseases such as the measles, scarlet fever, diphtheria, and the like. Systemic diseases of the body such as diseases of the heart and vessels, of the lungs and the kidneys and each others. Depend on the degree of stenosis treater develops. Examination reveals reaction of the supraclavicular fossa and intercostal spaces, and respiratory rhythm becomes upset. If stenosis persists, the pulse is accelerated, the lips, the nose, and the nails become cyanotic due to accumulation of carbon dioxide in the oxygen deficit and decentration of the blood circulation. Inspiratory dyspnoea develops simultaneously. The following stage is classified in the clinical course of the stenosis. There are 4 stages, and the first degree we call this the compensation stage. The second is the subcompensation stage. Third degree is the insufficiency or decompensation stages, and the fourth stage we call this the asphyxia. During the compensation stage, the patient does not develop respiratory distress at rest, but tachypnea develops during walking. The width of the glottis is 6-7 millimeters. During the subcompensation stage, the patient develops inspiratory dyspnoea at rest, with involvement of the accessory muscles in the respiratory act. In the intercostal spaces, soft tissues of the jugular and the supraclavicular fossa are retracted. Stridor, pallor, and restlessness are characteristic. The glottis is the measures of the rima glottis is 4-6 millimeters. During the third stage, I mean just the decompensation stages, it's characterized by shallow and accelerated respiration. The patient assumes a forced position, half sitting in his bed and holding fast on the headrest or some other object. The larynx moves to maximum possible distance up and down. The face is pale and cyanotic, and the patient is frightened. He perspires. His lips, the nose tip, and the terminal phalanx are cyanotic. The pulse is fast. The glottis is 2-3 millimeters wide. During the decompensation stage should be treated surgically. Immediate tracheostomy or intubation are indicated. The patient can be intubated with elastic tubes used for intratracheal anesthesia in intensive therapy departments. Asphyxia stage requires urgent conicotomy and then the tracheotomy. The conservative treatment during the stenosis, if it is related with the infections, should be antibiotic therapy, antihistamine therapy, corticosteroid therapy, and such cocktails with the calcium glucose vitamin J is also effective. About the chronic stenosis, it arises due to persistent morphological changes in the larynx and the adjacent organs and tissues. As a rule, chronic stenosis develops slowly and gradually. Causes of chronic stenosis of the larynx are quite varied. Common causative factors are chondroperichondritis, disturbed mobility of the cricoarytenoid joint, dysfunction of the inferior laryngeal nerves due to toxic neuritis following the stomectomy, compression by a tumor and the like tumor, tuberculosis, syphilis. Patients with chronic stenosis of the larynx often develop bronchitis and emphysema due to long-standing hypoxia. Bronchopneumonia is frequent in children. The heart is enlarged and the myocardium hypertrophied. The treatment of chronic stenosis is often very difficult, and in some cases the lumen of the larynx is restored to normal size only after prolonged treatment. Spatial dilators are used for regular artificial dilatation of the stenosis larynx. Laryngostomy and prolonged for some dilatation of the larynx by T tubes, better plastic, give more reliable results. About the tuberculosis of the larynx, it is the most frequently occurring tuberculous affection of the airways. The larynx is infected with tuberculous mycobacteria mainly by three routes. The most common of them is contact infection with sputum expectorated from the lungs of patients with pulmonary tuberculosis. The other route of ingress is with blood, hematogenic route. The third way of infection spreading is by lymphatics. Three stages are distinguished in the development of a tuberculous process in the larynx. The first stage is infiltration, the second is characterized by formation of ulcers, and the third stage is associated with affection of the cartilage and perichondrium. The vocal function is upset only in cases when the vocal or vestibular folds and the interarytenoid notch are involved. But the most common sites of infection residence should be remembered. These are the interarytenoid spaces, arytenoid cartilage, and the adjacent parts of the vocal cords. Tuberculosis of the larynx progresses slowly. The treatment should first of all be aimed at elimination of the main disease, and you should use just a combined local use of the preparations believed to have the rest effect with the anti-physiatric drugs. About the syphilis, in that slide we can see the laryngoscopic view of the syphilis. It is the secondary stage is manifested. It's extremely rare cases. Secondary stage is manifested by the erythema simulating cataract laryngitis with the involvement of the mucous membrane of the vocal folds, arytenoid cartilage and epiglottis, and also by papules and large condylomas. The tertiary stage of syphilis of the larynx occurs mainly in males aged from 30 to 50. Gammas are located mainly in the epiglottis and less frequently in the interarytenoid notch and on the vestibular fold. When located in the infraglottic space, a gamma appears in the form of a symmetric infiltrate. Now about the tumor-like productions, all this just obligatory diseases. For the tumor-like productions include just the laryngeal polyps, laryngeal nodule, cyst, and laryngeal cells. In that slide, we can see just the view of the polyps and the nodule. It's also the laryngoscopic view of the polyp, laryngeal polyp. Now about the vocal fold nodules, the etiology of this is the excessive or improper vocal use. The clinical manifestations is the hoarseness. The signs you see is the small smooth nodule on the anterior third or just a free edge of each chord, and usually it occurs bilaterally, and it is you see it is symmetrically located. The treatment may be with the vocal arrest, speech therapy, and with the medicine sometimes we are using. During the fibrous typhus, we should do the surgery, microsurgery. But the surgery should not be in children. Okay, it's the vocal fold cyst. It is the laryngoscopic view of the cyst. About the tumors of the upper respiratory tract, the neoplasms of the upper respiratory tract average 3–4% of all tumors localization. The tumors of the larynx average more than half neoplasms of upper respiratory tract. Tumors of pharynx are on the second place. Tumors of the nose and paranasal sinuses are on the third place. Neoplasms of ear are met much rarely. Benign neoplasms are characterized by high degree of differentiation, not infiltrative and not destroying growth. They don't give metastasis, don't relapse, and are resistant to radiotherapy. Papillomas, hemangiomas, and fibromas are the most frequently occurred benign tumors of larynx. Just the benign tumors we can show as example the papilloma, the angioma, fibroma, It's the pictures of the laryngeal papilloma in adult, but it's more common in children. Okay, it is the laryngoscopic view of the laryngeal papilloma. It is one of the first place among of the most frequently occurred benign tumors of upper respiratory tract. This tumor develops from flat and transitional epithelium. The most often papilloma becomes localized in larynx and may occur at any age. Children are affected by papilloma between a year and a half and 5 years old. Multiple papillomas are found on vocal cords, extend down to subglottic space and trachea, restrict gap of larynx, and cause difficult breathing. During first 5 years of child's life, papilloma grow fast, often relapse in spite of therapy, but almost are never malignant. During puberty, papillomas may disappear spontaneously. The heart papilloma with papillary crawling growth is found in every fourth case, such as papilloma to it's just a causes transformation to squamous cell carcinoma. It is found in 15% and gives grounds for the papilloma of larynx and adult as obligatory precarcinoma. The vascular tumor among benign tumors of upper respiratory tract are the second. It is usually hemangioma. In larynx, fibroma proceeds benignly. It is usually solitary tumor like millet or no bigger than a pear. The treatment of the papilloma, it's sometimes we need to do just the surgery, mostly via endoscopically, just the antiviral therapy and immunotherapies also has positive effects. During the surgery, it settles down on three sides of vocal cord. Just the fibroma of larynx manifest by a violation of voice, sometimes cough, and very rarely hard breathing. Fibroma is removed by laryngeal assays during laryngoscopy with laryngeal forceps. Now about the cancers of the larynx. Just during the etiology of the smoking, alcohol abuse, virus infection, environmental factors, the sexual hormones also plays roles. Has just the etiological just the factors. This pathologically, it's sometimes just commonly squamous cell carcinoma is occurs. The classifications of the tumors, there are so many classifications of the tumors, so we can classify this with the TNM and so many classification, but we can classified it with the localization, related with the localization. There's a supraglottic carcinoma, glottic, subglottic, and transglottic carcinoma. If these lesions are detected early, they can be treated with either radiation or surgery with a cure rate approaching 90%. Okay, we said there are so many classifications. We can classify it actually as a supraglottic, glottic, and subglottic. Just it's the view of the supraglottic, the glottic, and subglottic cancers view. About the laryngeal disorders, just laryngeal, just the paralysis and paralysis. It also classified the neurogenically and myogenically. Neurogenically, it's also classified to central and peripheric. Central, it's divided to organic and functional. Peripheric, it's the unilateral and bilateral. Myogenic, it's related with the inflammation of intrinsic muscles. The disease of laryngeal motor nerves leads to disturbance of the motor nerve of laryngeal muscles that cause just TBC motion disorder. Just etiology, maybe just a centric and peripheral disorder. Vocal cord paralysis or paresis results from a lesion of the neural or muscular mechanism. It may be unilateral and bilateral. When we say the unilateral vocal cord paralysis, it can be caused by a variety of diseases or disorders that prevent movement in one vocal fold. When one weakened vocal fold does not move well enough to meet the other fold in the midline during speech, ear leaks out too quickly. This causes the voice to sound breathy and weak, making it necessary for the speaker to take more frequent breaths during the speech. After a full day of talking, someone with a weak vocal fold can feel exhausted due to the frequent breathing and can experience choking and coughing on food or liquids. In the bilateral vocal folds have movement problems. The situation can be much more serious. With both vocal folds paralyzed in the midline position, the person has difficulty breathing in. A tracheotomy may be necessary to establish an airway. If both folds are paralyzed near the midline, also the voice may be good, the airway may be compromised. If both folds are paralyzed far apart, there may be no voices. For example, it is the example of the left vocal cord paralyzed. The right vocal cord is normal, that's why it's located more midline, but it cannot move. That's why during the vocalizing there's the left vocal, there's the rhizoglottis is open, staying open. In that pictures we can see the left laryngeal nerves paralysis. Here we can see the incomplete bilateral recurrent laryngeal nerve paralysis view. The treatment, we can treat it with etiologically and symptomatically. Symptomatically include the local injection and surgery. The voice training, tracheotomy also sometimes we should do such of the intervention. Okay, in that slide you can see the post-intubation contact granuloma of the larynx. It happens after the long-term period living of the two intubation tubes in the laryngeal rhizoglottis. Okay, during the stenosis, we should do such of the methods. One of them it is the tracheotomy. In that slide you can see just the stages of the tracheotomy. Okay, our laryngeal disorders, we had just two separately lessons, and our time so limited during the lecture time. That's why we explained all with detail our practice lessons. See you.